As we meet here today, the World Health Organization has identified 837 cases of Ebola in the Democratic Republic of Congo, with 196 confirmed deaths. These are likely underreported numbers. An additional 19 cases have been identified in Uganda, with 2 confirmed deaths. Health experts believe this outbreak could be the most serious Ebola crisis ever recorded. Caused by the rare Bundibugyo strain of the virus, the outbreak has spread across multiple provinces and international borders. Our speakers today will discuss the Bundibugyo Ebola virus and its rapid spread. There is currently no vaccine against this strain. Speakers will also discuss armed conflict throughout Central Africa and how regional warfare hampers aid efforts, including the mistrust of public healthcare settings. They will also address the misinformation stemming from the region and the African American diaspora's response to the crisis. So, with that background, please welcome today's speakers. Dr. William Schaffner, a consistent presence at these briefings. Dr. Schaffner is the professor of preventive medicine and infectious diseases at Vanderbilt University School of Medicine. Dr. Rachel Sweet, assistant professor of global affairs, at the University of Notre Dame and core faculty member of the Kroc Institute for International Peace Studies at Notre Dame. And Pamela Asobo-Anchang, editor-in-chief and publisher of Immigrant Magazine, and one of our colleagues. So welcome to all of you.
I'm charged with giving you a little bit of a primer on the Ebola virus. It's a part of a group of viruses that are called the viral hemorrhagic fever viruses. That's a very scary name, but the scary name, I'm afraid, is justified. This particular virus is maintained in the wild. Its reservoir, the place where it circulates most in the wild, we think is in fruit bats. Now, how does a virus that circulates in the fruit bats get into humans? Well, there are 2 good theories. The first is that hunters going out may hunt fruit bats as bushmeat, and in the cause of butchering the bats, they may cut themselves or have blood from the fruit bats enter cuts and scrapes that they already have on their hands. That would introduce the virus into the body of a human. Another way, and I think this is the way the outbreak in 2014 in in West Africa occurred, is that a fruit bat ate a piece of fruit, dropped it uneaten, not completely eaten, and a young child then picked it up and mouthed that same piece of fruit, being exposed to the saliva of the fruit bat. And that probably initiated that outbreak in West Africa back in 2014. In any event, once the virus is introduced into the body, we say it incubates. It begins slowly to multiply in the body, but the individual is not sick. The interval between exposure and illness can be days or even weeks, so it can be quite lengthy. Some of this may depend upon the dose, the amount of the virus that's initially gets into the human body. It doesn't take many viruses to initiate an infection. In any event, after this incubation period, the individual becomes sick. Fever is very characteristic. It can go from low grade to very high grade and may change over time, getting worse. And then along with that are a whole series of non-specific symptoms: aches, pains, not feeling well. You can get some headache, a loss of appetite. In these early stages, And during the incubation period, I will say this again, the person can be sick, but is still not at risk of transmitting the virus. In any event, the virus continues to multiply within the body, making the individual progressively sick. Nausea, vomiting, diarrhea. Some patients do have bleeding episodes, so-called wet disease. Those body fluids, the vomitus, the diarrhea, and the blood are highly infectious. As the person becomes progressively ill, loses contact with reality, slips into coma, blood pressure drops, and you have multiple organs dysfunctioning, the lung, the liver, the kidneys, the heart. You develop a profound illness. You require much more direct medical care. People, family members and friends may actually do a lot of hands-on care, caring for the individual. As the individual becomes progressively ill, the virus spreads throughout the body. And indeed, it's these contacts that are involved in the medical care by family and friends that are highly dangerous. And furthermore, when the person dies, they are essentially covered with the Ebola virus, even in their skin. And therefore, the respectful burial practices that are so culturally important, showing affection and respect to the person who's departed, are actually very, very, very dangerous for transmission because the body is cleansed. People wish to touch the body and even kiss it. And it's in that close association that the virus can readily be transmitted to caregivers when you're very sick and to people who are preparing the body for a respectful burial. That's why it's so important in the interventions to contact all the local leaders and educate the populace that these centuries-old traditions of how to show respect to the departed person must be changed in order to intervene to prevent transmission. Now, the treatment for Ebola, if you can get it in a major medical center, is supportive care. We have no direct antiviral drugs that will treat this infection, but through very highly sophisticated supportive care, dealing with all the deranged organ systems, people can survive. And that has been clearly demonstrated in the developed world if people are transported, for example, to the United States, but also locally, people can survive. Now, how do we try to curtail this outbreak? If we had a vaccine, that would be wonderful. The Ebola virus presents itself in 6 different species. They are quite distinct. We have vaccines against some of them, but not one against the Bundibugyo strain, which is causing this disease. So one of the public health interventions that we would like to use is, at the moment at least, not available to us. So we want to find cases. We want to get them into medical care so they can get good medical care with infection control procedures. We wish to contact everyone who's been exposed, isolate them, observe them. Should they become sick, quickly bring them to medical care and not have them exposed others to prolong the chain of transmission from one to another. This is very difficult, and we will hear from Dr. Sweet and Ms. Anchang about how difficult it is to institute these procedures locally. Things have been made worse, of course, because there has been a diminution in resources recently by the WHO and our own government. And that's resulted in a delay in diagnosis. But now the WHO and other is organizing other countries to bring in personnel and medical equipment, testing equipment, and the like. This is going to be a long-term issue. You can see from what I've said that the capacity for spread locally is real, and it can continue to spread because we have limited interventions in an area that is remote and is politically troubled. However, in contrast to the local spread, the risk of transmission to other parts of the world remains very low. And if a patient is indeed found somewhere else in the world, they can be isolated very quickly and taken care of very quickly with little or no spread. That was certainly the circumstance in the West African outbreak 10 years ago. We had essentially no spread to the developed world, whereas all the spread was localized to those several countries in West Africa. I think I will stop at that point, and I'm happy to respond to your questions.
Dr. Schaffner, there are several questions for you in the chat, but I wanted to start first. Given the fact that most of the cases that have been identified are in rural communities, do you believe that there is an underreporting of cases?
There always, in circumstances such as this, is an underreporting of cases and deaths for a variety of reasons. There are a lot of people who are shamed by this. There are people who don't wish to interact with the government and report this kinds of information. And of course, as I said, the initial symptoms may be misdiagnosed as they were early in the outbreak, and it may not be recognized that each and every patient has Ebola. So the counting of cases is behind the extent of the epidemic in actuality on the ground.
Thank you. I have more questions for you, but let's go to the chat. All right. So we'll start out with Aitana Vargas.
Hi, can you hear me?
Yes.
Oh, thank you, Sunita. Thank you, everyone, for this briefing. I wanted to know what the impact of Trump's policies and cuts when it comes to USAID would have in a crisis like the one that we are seeing right now. Thank you.
Great question, Aitana.
Yeah, as I alluded to, it's clear that the United States has withdrawn a lot of aid. And I think diagnostic capability, clinical expertise, communications, all of those things were impaired and likely contributed to a delay in diagnosis. It was also that this is a rather remote area, and there was already political turbulence. We'll hear some more about that in just a minute. That also likely contributed to a delay in diagnosis.
Dr. Schaffner, we're having the World Cup all over the country. And of course, we're getting visitors from many countries, including many countries in Africa. So what's the actual risk of this variant of Ebola spreading in the US?
Well, Nestor, I think, as I said, the risk is very, very low for a number of reasons. First of all, this is a rather remote part of Africa. I don't anticipate that too many of these people who do not have very many financial resources will be traveling to the World Cup. So that already reduces the risk very substantially. And if there were someone who comes to the United States, whether to visit the World Cup or for any other occasion, to develop Ebola, this did happen back in the West African outbreak. That person is fairly quickly diagnosed and isolated, and there was no spread from that person back in the West African outbreak, who was hospitalized in Dallas as it happened. But certainly, I think these person could be identified and contained with appropriate infection control in all of the Western developed countries.
The latter half of my question is it originated from not knowing they have it. What protocols are in place in case it happens?
Well, the protocols that are in place, Renee, have to do with the fact that I think every hospital in the country is alert to Ebola, and questions are being asked to patients who come in who haven't had a fever, whether they have had any travel history, and particularly travel to East Africa or Central Africa at the present time. So I think people are looking for patients who might have Ebola. This certainly happened in my institution during the West African outbreak. We had several candidate patients, but they never turned out to have Ebola, but they were identified as travelers who might have been at risk, and they were immediately isolated and they were tested very quickly.
When can we expect an approved vaccine against the current strain of the virus? And Dr. Schaffner, I would like to ask, can we use the existing vaccine to mitigate the impact of Bundibugyo?
Yes, Anita, I would wish that we could use the currently available vaccine to help us in this circumstance. But unfortunately, the 6 different types of the Ebola virus are sufficiently different so that we have to have specific vaccines developed for each. There are laboratory scientists working night and day to try to develop a vaccine against the Bundibugyo strain of the virus, but it's not there yet, and we have no immediate near-term expectation that we will have a vaccine available. So we will have to rely on traditional on-the-ground public health interventions, finding the cases, isolating them, contact tracing, putting them in quarantine, working with the local leaders, and those sorts of things. Not easy, but those things have worked in the past to curtail outbreaks.
Yeah. And we'll get to you for a final round of questions. And I see there are many questions for you. If you could answer them there, and then we'll take them live, time permitting. Thank you. We next welcome Dr. Rachel Sweet, who will talk about armed conflicts and how those conflicts might hamper our ability to mitigate the Ebola crisis. Welcome, Dr. Sweet.
Thanks, Anita. I'm so pleased to be here with you all today. So I'll be drawing on 5 years experience on the ground in DRC in various capacities, including as an investigator of armed conflict. And I'm also drawing on numerous conversations I've had over the past several weeks with people on the ground, from healthcare workers to community leaders. The starting point is that there is a twilight zone of difference between how these areas are portrayed, typically internationally, and what they are like on the ground with the lived experience of being there. Typically, we hear about these areas being reported through journalists who oftentimes aren't able to be directly on the ground or to get outside of fairly narrow parameters of compound walls and how to operate with various escorts. So I'd like to try to bring you down to what the vantage from the ground actually looks like, and I'd be happy to take more questions later. The first thing I would put to you is that it's not the conflict itself that is going to be the key obstacle to containing the virus. Instead, it's our cliches about the conflict and about the communities living under it that tend to preclude the most effective action that could be taken. Oftentimes, conflict in this area is depicted as if it were ethnic militias, as if it were these militias linked to foreign terrorist groups. and as if it organized beyond the state, as if this is a stateless, ungoverned, remote area. And the reality is that for decades, since the initial Congo wars of the 1990s and early 2000s, violence and the state are deeply intertwined. And this is the primary security threat to the current response, and is also what makes conflict so intractable. Rather than conflict organizing beyond the state, armed factions have executed and exercised control through the bureaucracy, through customs bureaus, through everyday state taxation agencies, through taking over the national police, and also through capturing and taking over the ministries of public health, of social affairs, both on the provincial as well as the national level. When armed groups integrated, then defected, then reintegrated again into the military and into the government, those networks and those connections, that intertwining with the state remained. Same goes for conflict minerals. We oftentimes hear about this area talked about as flush with gold, and certainly there is gold in Mongwalu, and certainly there are armed groups. However, it's the organizational structure of how these networks and groups operate that is so important. Organizationally, people on the ground at mines, including commanders and militias there, typically respond to a political and a military hierarchy that is not in those areas at all, that live in regional capitals, live in provincial capitals, and the national capital. And the same goes for armed groups. I'm going to give you, I've changed all the names, so I'm just going to also lead with that. But I'm going to give you just some examples of what active combatants and active military officers have to say about how the conflict organizes. This is not what you can read in the news because it's so dangerous to share. It only gets shared behind closed doors. But one example is from Jean, who is a former combatant. And Jean, behind closed doors in his language, speaks about how when he was in the armed group, his commanders were colonels in the national military at the same time that they were generals within the armed group. And so instead of just a rebel organization on their own, the leaders are often intertwined with the military. Here's another example from Charles, who is a military officer himself, who says that, quote, "I cannot write about the real involvement in the security threats in these areas for fear of being killed by my superior officers," because he doesn't want to implicate them. So he cannot put the military involvement within the reports that he issues. Instead, they use a euphemism and they attribute it to a different armed group. These types of practices are what coercion looks like. This is how people adapt under violence. So the state and violence are deeply intertwined. This creates a much more pernicious and difficult context. And this is not just in Congo, it's violence across the world, but it creates an environment that's much more difficult to contain than if it were remote and if it were totally separate from the state. Because what this means is that the same authorities that everyday civilians fear, and they fear that these authorities are going to come and show up in death squads and organize killings of mass civilians that have been going on for years. Those same authorities are now the authorities that the health response, the Ebola response, partners with hand in hand in order to try to curry local trust within the Ebola response. Now, in the past Ebola epidemic in the same area, a different strain, but a similar political dynamic, people were afraid because they saw that the same pickups, the same military pickups that were protecting the Ebola response, they were also the same ones that could come at night and that could slaughter your family. And so when there was resistance against the Ebola response, a lot of it was resistance against these security threats. The security threats, they're not misinformation, they're not perceived, they're real, and they get mapped onto the Ebola response if the Ebola response doesn't take proactive steps of of separating that political context. And so where cliches get in the way is if we imagine that conflict is non-state, if we imagine that conflict is primitive, and then we also imagine that communities living in these environments are traditional or uneducated or are just innately hostile in some ways, what we've actually done is missed the main mechanism that drives mistrust in the first place and that makes distrust of authorities entirely rational. What we've also done is missed the really important ways that the Ebola response must adapt to this environment in order to depoliticize its own involvement in this environment. And things that are important to do to depoliticize involvement are things like restrict international propagation of information about this area to facts that are vetted and well corroborated. Attributing violence to armed groups is a very delicate investigative process that requires strict evidence. And typically when you read in the news who perpetrators are, that process hasn't been followed because it's a difficult process. It takes time. But if the same journalists or the same members of the response are talking about the conflict as non-state and as community members as hostile, what they've done is inadvertently taken sides within a conflict that is difficult to understand. There's other things like who the doctors are. Are they dispatched from Kinshasa or are they local doctors? All of this sends signals to people about whether this is politicized, whether they can trust it or not. We do hear that some people are skeptical of Ebola. And again, within the context where the government doesn't always provide accurate information, where the previous president is under sanctions for helping to organize an armed group currently in Congo, it makes good sense to not take the government at their word. So when we hear like skepticism, like, oh, is Ebola real? What's important is that we can interpret that not as, hey, these people don't have scientific medical understanding, but to interpret what the underlying valid concern behind that is. And that valid concern is this going to be a mechanism for disenfranchisement, as it was in the previous epidemic? Is this going to be a mechanism that's going to increase my security threats? Is this going to be a mechanism that detracts information away from my primary concern, which is the security threat, which are the massacres going on? If international attention just jumps to Ebola and misses everything else, like then people feel that their primary concerns are not important to the international community. And the only thing important to the international community is preventing the spread of this disease to the global north. I just want to, so I have many other things to say, but I'll save some of them for questions. Feel free to ask me about burial practices, etc. But I do just want to leave you with some other realities of who the people on the ground are in places like Bunia and places like Beni and Butembo that are preparing for this epidemic. In these areas, you have pastors, you have Congolese professors, you have app developers, you have all across the board avid World Cup spectators, you have university students, and you have mothers who try like so hard to put their kids through school. And if their experiences aren't like reflected in the way that reporting is done about these areas, then it's difficult to demonstrate to the community that we're really here to listen and to work hand in hand. In these areas, you have doctors who have been organizing before the World Health Organization showed up and that have been proactively trying to petition the World Health Organization and other NGOs in order to improve treatment in their areas. You have nurses who are going unpaid, who are leaving their jobs in regular hospitals to take more risky posts in Ebola treatment centers before they're fully stocked because they're consummate professionals and because they care about their country. We have doctors who are already anticipating the difficulty of mobilizing the population and who are taking steps today in Beni, for example, of opening up the Ebola treatment center so that religious authorities, the local leaders can come and view it and have more of a community exchange around this. And so I would be remiss to leave you all without at least mentioning the massive on-the-ground mobilization that is already underway, that does need resources, but above all goes unpaid, unrecognized, but is entirely valuable to containing the spread. Thanks.
Thank you, Dr. Sweet. You're addressing a room full of reporters, and you talked about the misinformation that was coming out of the region with reporters that are allowed to enter, but in very curated circumstances. Could you describe those curated circumstances and also explain how this leads to misinformation coming out of the area?
Yeah, absolutely. So I'll give a really historic example, then I'll give a more recent one. I want the historic example just because it demonstrates patterns over time and how long this has been going on. So even within the Second Congo War, journalists, I'll use the example of a journalist from Radio France Internationale, arrived in rebel territory, but alerted the rebels that they were coming. So the rebels paid for the hotel and created escorts so that they could escort the journalist to different sites on the ground. More recently, journalists oftentimes who are able to go, because it's a conflict zone, typically go with a military escort or with security. Now, if I were to go to these areas with a military escort, I would be very unlikely to hear about civilians' concerns about the rampant human rights atrocities that are being perpetrated by the military, because those things are dangerous to talk about in front of the military right there. These are also areas, and conflict in general, information that is available is typically systematically different from what is kept hidden underground, because what's kept hidden is really sensitive. It's really dangerous to really talk about who the main actors are, and oftentimes it's not entirely clear, although people have a sense that indeed there is government involvement.
Yeah, Christopher Young had a similar question. Christopher, have you gotten a sufficient answer, or do you need a further clarification?
Thank you, Sunita. I just wanted to go to a deeper level with the cliches that you mentioned at the very onset.
So the main cliches that I would draw attention to are the nature of the conflict being non-state in nature, being which, if we use that lens, precludes our ability to understand how local authorities, national authorities are also complicit in the conflict, and why people respond to that in a way that makes distrust of authorities rational. So if we don't, so if we're looking at the conflict through the typical cliche of these are ethnic militias linked to foreign terrorist groups, what we've done is completely erased involvement of local authorities, of the government and the military in the first place. And then we've inadvertently precluded the ability to understand what people's source of concern in this area is. Also, if we emphasize the conflict as local militias linked to foreign terrorist groups, what that does is give the impression that people on the ground act from motives that are more traditional in orientation, rather than like contemporary. These are people who live in a contemporary political environment, and their concerns are contemporary. They're political in nature. One of the reasons that burials are so important in this area is absolutely to respect the norms of what burials typically have meant. But also, if you're in a conflict environment and you see bodies disappear and you're not able to see those bodies and where they go, that looks a lot like forced disappearances. That looks like a lot of what the concerns about violence have been. And so aspects of like safe and dignified burials that were already like underway. Let's not recreate the wheel. That's what one of my colleagues in Congo told me about the safe and dignified burials. They figured out how to do it in 2018 to 2020. We can implement that same procedure now. But what was really crucial was for someone, a representative of the family, to see a body, at least from a distance, because what that visual verification does is also validate that the Ebola response is not indeed part of the conflict. And so it's not just the traditional concerns, it's also the contemporary political concerns that are like so crucial when we talk about these things.
Of course, I mean, the US seems to be in the habit of intervening in many parts of the world. And my question is there any role in this case? I mean, is there a role, if any, of the US in terms of shaping these internal conflicts that you keep talking about? Thank you.
So there's absolutely an important role for the US to play for the epidemic in terms of being able to deliver resources. Doctors on the ground have been asking for better testing, have been asking for better facilities to contain Ebola, and are like being very proactive about that. So a really important role to play in supporting the response. For the US involvement within the conflict, it would be important to foreground real investigative expertise rather than throwing money through national channels at a conflict that is difficult to understand, because resources can be misallocated, because armed groups even 3 decades ago were receiving just as much money from peace processes as they were from diamonds, and are able to replicate those conditions still today. So without clear, I would emphasize the need to support commissions of inquiry to submit higher quality investigations across the board within Congo and other environments.
Our next speaker is one of our colleagues, Pamela Asobot-Anchang from Immigrant Magazine. Pamela will discuss the African American diaspora's response to the crisis, possible aid attempts from the U.S., and voices from the ground in the region. Welcome, Pamela.
Hello, thank you for having me. It's an honor and a privilege. I've listened to the scientists share amazing points of view, and I'm going to try to bring a different perspective. I was really hoping that I could get a voice from the ground, but I didn't succeed. But I talked to people that had traveled and were here as well. So in a way, it's kind of voices from the ground. I spoke recently, last weekend, actually, we had something called Destination Africa. So we're celebrating the World Cup, and that was a great opportunity to kind of sample different voices. So I spoke to Cameroonians, Sierra Leoneans, Nigerians, Ugandans, even community leaders from the DRC, the affected regions. And I can tell you that I had a mixed bag of responses. Some were a little shocking and some were expected. Well, for me as an African, I realized that even I hadn't been paying attention. So that was the general sense from the diaspora, that people were not paying attention, especially those who were not directly affected. So some of those I spoke to, those that were not concerned, strangely enough, I spoke to the president of the Ugandan community. And as we know, Uganda is one of the regions that's affected, not as greatly as the DRC. So I was expecting to hear that the diaspora was very much involved and scared and all of that. And surprisingly, she shared that her community wasn't concerned. She even said to me, "What Ebola?" I was like, "Well, what about the deaths that are being reported and everything?" And she said they were very skeptical about the information, the veracity. And so she sounded very defensive. And even I, as an African sister, but I was coming from a professional point of view, but talking to a fellow African, I felt I wanted her to trust me, and so when I tried to verify that information, she shared with me that she had just come back from Uganda and that that to her there was nothing, and that the screenings that were even being just talked about screenings when you traveled and you came back, well, how was it? And she said it was basic. That was just simply temperature taking, like normal screenings, healthcare screenings, and nothing that she felt kind of like related to Ebola. Well, I'm just gonna say she's the president of the Ugandan Association, and so I wanted to know if there were any organizations, any efforts by the diaspora, the Ugandan diaspora, to help back home. And she said, well, since to them there's nothing really happening, they were not doing anything. So then I was okay. So I moved on. Another person I spoke to was somebody from the Tanzanian community because I wanted to get an idea. Tanzania is East African country, doesn't share direct borders with DRC, but they have indirect borders. Some countries have indirect borders. And she too wasn't alarmed, she wasn't concerned. They weren't worried about Ebola. It's not even a thing. So then I also got the opportunity to speak to other communities. I spoke to some members of my community, the Cameroonian community, just so happened to be playing soccer on that day. And so I spoke to them, and surprisingly, Cameroon doesn't really share direct borders with the DRC, but we share borders like with Congo, which is there's DRC and then there's Republic of Congo. So we don't share direct borders, but the Cameroonians were concerned and were really worried about possible spread into Cameroon, and that what they were doing now was the least they could do was send money back home. Sanitation is a big problem. Lack of water, clean water is a big concern, and fear of going back home. So, and then one of them shared something that was really disturbing to me. The misinformation, lack of education was a big problem, and that people would revert to thoughts of superstition as opposed to the science of what is going on. So that lack of education was a big issue. There's no accurate information coming in, and people now start to find, answers where, there's no help, and the fear spreads, and superstition has really become a big problem. So then I also spoke, I know we don't have too much time. I also spoke to members of the people that are really involved, at least 4 people from the DRC I spoke to. And they spoke to me on camera, but they didn't want me to quote them or, be specific about them. But they said they were very afraid that it was real, which was strange because the Ugandan sister I spoke to denied it completely, or, was skeptical. But the DRC community is really, really afraid, really affected. They said they worry they can't go back home. That is a big concern for them. Some of them have invested back home and now they can't go back home. And all they can do is send money and make calls through WhatsApp and check on their relatives every day. The emotional burden is really taking a toll. They know if they go back home, they won't be able to come back to the United States. So because of restrictions and all whatnot. And they really expressed real deep regret about the reduction in international assistance, including the closure of the USAID, supported programs that have made to them, insufficient access to healthcare and to help, resources and they have a really fragile healthcare system. And so they worry about that. And stigma was the big, big concern for them as well, because once they felt like if they said, I'm from the DRC, people begin to wonder, and so that was a really big concern for them. And then I also spoke with some Nigerians, and I stumbled on a Nigerian attorney who had represented during the West African Ebola crisis, a nurse who had been in Sierra Leone, and then she had returned to the United States working in the blood bank, apparently, and she lost her job. And at the time, he didn't know, he couldn't hide, but he says, looking back in retrospect, it would appear that she had suffered from being stigmatized. well, and now he didn't know, she lost her job basically. So people now, he's meeting clients who are afraid to even go back home for fear that they might lose their jobs and stuff like that. So that is a problem for the diaspora, identifying with countries that are affected by the crisis, by the Ebola crisis. So it really, really, really was tough. And then I recently spoke to somebody. I was like, okay, so now what are we doing though? Because from the DRC, I asked also, said, is there any organized structure for help to help? And they said, no, there was no coordination, perhaps in Europe, but not here in the United States. They didn't have anything going on, and everybody was just doing it at their own pace, individualistically, and helping their families. So, however, I spoke with the president and founder of the Africa's Brain Bank, which is like an organization that is a repository of African diaspora brains. She created this foundation to bring African resources, whether it's scientists or STEM, all of that. So I wanted to hear from her, and I was hoping that she would lead me to some of her members, but I think given the time, we were not able, but she gave me a statement. And she said during the Sierra Leone crisis, they had, as an organization, assisted in creating, in providing resources. They had boreholes for clean drinking water, rallied a lot of resources to bring help to the people on the ground. However, she lamented that the problem with most of what is going on in Africa as a whole is that it's reactionary. People take action when there's a crisis, and when there's no crisis, people forget. She said there are relics of USAID, UK aid in some of the structures that were left back home, and whereas there's nothing going on, the boreholes which contain water had dried up, and the people were left to their own means. And so now with this current Ebola crisis, they're rallying themselves. They're looking for partnerships to see how they could actually assist, but then they're fed up with the crisis action. They want things that are more sustainable. And so she did share with me that they have a summit coming up this September. And the goal is they have this project to build a medical center in Ghana that they hope would be state of the art, the best, maybe something that, would not just focus on when there's a crisis, but that it would also assist during times of no crisis. So in a nutshell, as you can see, it just depends because everybody's experience is different. Some people see Ebola as a real thing and some don't see it as anything. But I can tell you that as a diaspora, as the African diaspora in general, I don't hear much talk. And I belong to so many different WhatsApp groups because there are so many nonprofits, alma maters, and we all belong to all these groups. And I don't see a lot of activity going on there. I also know that from talking to people, even those that are not community leaders, they're not very eager to even discuss it. And I was really, really surprised. In a nutshell, that's what I uncovered.
Pamela, the type of apathy you just described, is this typical for those in the African diaspora? For example, what type of issues elicit group concerns? Was Trump's travel ban, for instance, an issue of concern?
Oh, yeah. Yeah, I think when it comes to subjects that would potentially bring out feelings of stigma, people are hesitant to own it. We are hesitant to own it because it would affect jobs, ability. People don't even want to identify with healthcare crisis. But for example, when President Trump with the bans, or when we called the continent not so flattering words, there was outrage. So the apathy is mostly, I'm seeing, and I was totally surprised because I wasn't expecting it. I thought by bringing up the subject, I would hear enthusiastic voices saying, oh, finally, someone is bringing this to the forefront. But I was those that were directly affected, like the members of the DRC, they were eager to speak. I spoke to more than 4 people, actually. They wanted to speak. And then for the Cameroonians, they also wanted to speak. So it just depended on who I was talking to. And then the Ugandan community, I tried to reach a few other people. I wasn't able to reach them. They didn't call me back. But finally, the president of the community called me back. And so she said she was not speaking for the government, but she was speaking for herself and her community. And I could sense a little resistance. So I really don't know how to answer that question. It just depends on what it is. But my sense is, because there is stigma attached to it, because she was like, what Ebola? Because she asked the question like, what Ebola? And I was surprised. And I said, well, there's like 19 deaths or something like that. How do you account for that? And she said, well, they're not even sure where that's coming from.
Thank you, Pamela. So the question to you is for the person who also lives in the US and can see the situation from different perspectives. So do you expect perception about the origin of Ebola to lead to increased discrimination or hostility towards Black Americans or other people of African descent, similar to the rise in anti-AAPI sentiment that occurred during the COVID-19 pandemic? Thank you.
Oh, that's a great question. But I think that's yet to be seen. Because, like I said, I spoke to this Nigerian attorney who had represented a few clients, and he said, I don't know if I'm answering your question, but this is something that I experienced with someone from Sierra Leone, and they lost their job. And he said he suspected that a lot more people would not be forthcoming to talk about this because of fear of that kind of sentiment of being stigmatized. So stigma is the big problem here, because we are living in a time where a lot of communities are stigmatized. There's hate and all of that. So people are afraid to even identify. And it actually got me thinking. Yeah, I don't know if that answers, but it's yet to be seen.
What role should the diaspora be playing?
Well, the diaspora should be playing the role it's always played. It's just in this case, I don't know why some communities are not taking action, because typically the diaspora has always supported the continent financially, resource-wise, advocacy-wise. And in this instance, some are doing, like I said, some people are just sending money to their family members just to get clean drinking water, because they feel like if the scientists or if the governments aren't doing the job, the least they could do is just provide clean drinking water. That's just very interesting. And they're sending money, which is what the diaspora always does. As you know, remittance to the continent is at all-time high, because we all have struggling communities. Diaspora is building clinics. Diaspora is building orphanages, building boreholes for drinking water and doing. So diaspora is already doing. It's just they need to amplify, and maybe our problem is that we're doing it individually, but we need to do collectively.
I'd like to conclude with a 30-second soundbite from each speaker. Why don't we start with Dr. Schaffner?
Thank you. I will continue to emphasize that the risk to the United States population and to the developed world of importations of Bundibugyo virus is very low. This is not a respiratory virus. It is not transmitted the way influenza and COVID viruses were. So I think we can rest pretty easy about that. But this continues to be a major local problem.
I would close by emphasizing the widespread mobilization by on-the-ground community actors, including doctors, healthcare professionals, nurses, as well as members of the Congolese diaspora and local pastors, local chiefs, in trying to mobilize support for the Ebola response, proactively reaching out to NGOs, to the World Health Organization, and asking to be recognized and to be valued for their efforts as well.
Dr. Sweet is from the Frontline Observatory. She's not with the University of Notre Dame anymore. So please correct that in your notes from this briefing. Pamela, final word to you.
I think for me, the biggest story is not just the Ebola outbreak. It's really what is revealing about misinformation, how dangerous that can be. It's even sometimes worse than the disease, and that stigma can outlast the virus. And so people are trying to protect themselves. And the African diaspora is really willing and has a compassion to help, but we just need support in coordination and, to make it count.
Fantastic. Speakers, thank you all so much for joining us today. We really appreciate you taking the time